right, this brings us to our final speaker today, Dr. Daniel Spratt. Dr. Spratt is the Vincent K. Smith Chair of the Department of Radiation Oncology and a tenured professor and chair of radiation oncology at Case. Dr. Spratt is an international expert in prostate cancer, clinical trial design, and biomarker development and validation. And today he's going to speak about genomic and AI-based biomarkers in prostate cancer.
So first, huge thanks everyone for being here today. I could spend all of this time thanking everybody that's been part of the research I'm going to show you. This is hundreds of people, probably over 40 grants, tens of millions of dollars that I am one very small part that I'm fortunate to present to you. So as I put this, and I like to start a lot of talks here when there are trainees, if there are any, as I say, even someone who's given thousands of talks, it's okay to get a little nervous. So everyone thinks none of the speakers are nervous, because when I was a trainee, I was like, how do people give all these talks? But anyways, hopefully this is an inspiration. So not just read the guidelines, create them. These are disclosures of various trials that I'm part of. So what the heck is the prostate? The prostate's a ping pong ball sized gland that gets a lot of attention, sits near the bladder and the rectum. It is the most common cancer in men worldwide. Almost 300,000 men will get it in 2024. It's just about 1 in 7. It's still about 1 in 8 they round up of men will get prostate cancer. So look around. Second leading cause of cancer death in men. It still kills more men every year than colorectal cancer, pancreatic cancer, liver tumors, brain tumors. So this is a real cancer. Fortunately, many men do very well with the therapies we have. Very unfortunately, it's the #1 cancer-associated cause of treatment disability. And this is because it has a long natural history. Unfortunately, there still is residual overtreatment of this disease. And the chronic treatment with chemical castration, which helps some of these men live for long periods of time, can be devastating. So how do we personalize treatment for this disease of these 300,000 men? Well, we do what's called risk stratification. So we use something created in the 1960s, we still use today, unfortunately, called Gleason grading by the famous Dr. Gleason. We use the PSA blood test, which really came into prime time in the 1990s. And then the extension of tumor, which thank goodness, this used to be by the rectal exam, now we do it by MRI. And when you combine these together in various ways, you create what's called the NCCN risk groups. This is basically our prognostic system that creates from very low risk all the way into metastatic disease. And the lower risk patients we now monitor. We actually don't treat. We don't treat their cancer, and that's the right thing to do. As you get into the intermediate and high risk, the backbone is either radiation therapy or surgery or both, but there's an increasing role of systemic therapy. And the systemic therapy in prostate cancer, the backbone is androgen deprivation therapy, or something that inhibits androgen receptor signaling. And so that testosterone, the main androgen in men, is made in the testicles as well as in the adrenal glands, and there's various drugs to inhibit this. As you see here, these all have effects, unfortunately, on the heart. The morbidity of ADT is non-trivial, okay? So, when we're reading and, textbooks and papers, it causes a variety of cardiovascular side effects directly and indirectly through metabolic syndrome, diabetes, high blood pressure, osteopenia. About 30% of men on long-term hormone therapy develop fractures, and lots of muscle loss. To patients, this is what they will say to each other. It made me fat, impotent, weak, I'm confused, I have no motivation, and I have bone loss. This is the #1 driver of quality of life decline in men predominantly with non-metastatic prostate cancer, because they usually die of something else. So in a perfect world, right, we would have a beautiful biomarker and a perfect drug or therapy for every single man based on their exact phenotype. We do not have this. And when I was in training around 2012, 2011, we treated all men on the far left. They came in, we got their Gleason score PSA, and I treated every single guy the same. as I'll show you over this about decade journey where we are now, is quite different. Unfortunately, I showed you the many different ways we prognosticate patients, but sadly, when you look at randomized trial data, so there's over 10,000 men in clinical trials, and you look at how good are these tools, the Gleason score, these risk groups, and this is why I say I want Gleason score to go away, is that this is an AUC, this is a measure of discrimination, 0.5 is a coin flip, and they're all not much better than a coin flip. That's really scary that we're telling guys to do just radiation all the way to multiple years of radiation hormone therapy plus other drugs. So let's change this. So this all started with, I was a resident at the time. This is a retrospective, I would call this, I'll be careful with the words I use. This is an okay retrospective paper to be published. It's Mayo Clinic, who has this monstrous repository of data into the 1980s. We identified about 400 patients that did not develop metastatic disease, a couple hundred who did. We did it, which for those currently doing gene expression data, we use something called a microarray, transcriptome microarray analysis, and 22 genes across 7 different relevant pathways, pretty accurately differentiated which patients would develop metastatic disease. This is where, and for those who review papers and grants, this is where probably 99.9999% of studies don't even get to this stage with clinical outcomes, but they don't go past this stage. This is useless. This is a nice paper. This is useless. This will never affect a patient's life if you stop here. So the next step is, okay, great, you did this in one study. We published in JCO in 2017. Let's look across numerous institutions, numerous studies, the VA. So we looked at Mayo Clinic, Thomas Jefferson, Johns Hopkins, the VA system, to show consistency, at least with these retrospective studies, that this may be something real. And then you look across black patients, white patients, different tumor stages, Gleason scores. Is this truly prognostic? Is this risk stratifying patients? Because if it's prognostic, it should work irrespective of all of these factors. A big problem with biomarker development is, right, all these clinical trials and the guidelines that are a result of it. You can't just say, wow, I've created this test. Now, this is how you should treat a patient. You have to somehow integrate that with the mass amount of evidence being constantly generated that's not using this biomarker. So we integrated this, we call it the clinical genomic risk groups, to take the NCCN risk groups, which define how we treat patients, and interlaced within it this genomic test. And effectively, what you see here is on the x-axis, this is the NCCN risk groups I told you, these prognostic groups, and the different bars are basically showing how it would be reclassified, given it's more accurate to use this genomic test. 2/3 of men would be treated differently and reclassified. So this, at least in clinic, lets you say, well, how should I treat a patient based on this biomarker score? And this is the biggest disservice to highlight this here. We validated this biomarker in 12 phase 3 randomized trials. That took years and years working with the NCI, with CTEP, with biorepositories in the US and internationally to show that across these disease settings, this consistently works, because you do not want to use a test or a drug in a patient that you're not very confident when you're going to change their management. And we updated this in 2022 across now over 40 studies we've done with 30,000 patients, that this is consistent kind of no matter how this is looked at. And then to make this something that others can look at, we work to partner what's called the GRID database. It's 150,000 patients that have had this genomic test with SEER, and you can link it. So now this is a variable, just like age and PSA is linked with SEER. It's not public yet. We get 2 years to publish away on it with SEER, but it will then be public for people to have hundreds of thousands of patients that you'll have their genomic information with real-world clinical outcome data. This led to 2 very large trials that I helped design through NRGs, over 5,000 patients in intermediate and high-risk prostate cancer, to personalize, based on this genomic test, the omission of hormone therapy or the intensification, so trying to reduce that over-treatment. But some men, like I said, still die of this disease. Everything I showed you previously with those randomized trials generates what's called Simon level 1B evidence, which is very good. This generates level 1A evidence. So that's part of the story, and that's all cool academically, but I want my patients to have this test, right? And they're not going to spend $5,000 a pop on a test like this. And so in 2019, based on a lot of this work at the time presented, and I did not name this video, I don't know why it's called the Daniel Spratt video, but this is Palmetto GBA that I went to CMS, flew out there to present to them why they should be covering this test, and created a dossier with the company. And this now is clinically available, covered by almost every single payer. The average price per patient is $45, so it can be used. And next, in the hardest bar, which there's only a few of these in all of the guidelines, is our NCCN guidelines, which is what insurance companies basically dictate what they'll cover, as well as, what our Bible of what we're going to recommend is now this 22 gene test is in the NCCN guidelines as the only level 1B recommended test. And next year, probably these other two you see here won't even be listed, because now that we have something that's level 1, why list something that has poorer evidence? It had direct treatment implications. This helps us guide the use of hormone therapy. It's something I order on pretty much every one of my patients now. So the question is, I fortunately was young when all this happened, and so can we do this again from the lessons over a 10, 15-year period to get to that? And we basically did and repeated it and accelerated it to just 3 years. And so everything I showed you is what's called a prognostic biomarker. Because prostate cancer can be indolent, if you can identify an indolent tumor, then why overtreat it? But if you have an aggressive tumor, it doesn't mean giving them hormone therapy will help them. That's a big misconception. So can we develop a predictive biomarker that, regardless of their prognosis, can intrinsically identify their benefit? And this is where they, skate to where the puck is going. And about 3 years ago, we said, well, what is all this AI buzz? I'm getting a couple little, feeds in my Google feed on this. Now it's everything. And we said, well, let's digitize all these tumors that we've been sequencing, and let's see if we can skip all that retrospective steps. Let's just jump straight in, get all the randomized trial data, train it on randomized trials, validate it, and see what we can come up with. And this would create the first ever predictive biomarker, which is what, again, I am just representing a monstrous consortium of work and AI scientists to do this. So we started with 5, now we have 10 digitized phase 3 trials. This is 4 randomized phase 3 trials, about 16 terabytes of imagery data. Just a single H&E slide is all that is needed. You don't need a tumor block. And we train this for the differential benefit of hormone therapy for these men. Critically important to validate a predictive biomarker is one of the hardest things you can do, because you need a randomized trial of the treatment of interest, plus or minus hormone therapy in this case, and identify what's called a biomarker treatment interaction. Are there some patients that benefit more than other patients? And to just jump to, the money shot here is this is distant metastasis, so the probability of developing distant mets. If you are what we call biomarker positive, based on this multimodal AI model, you have a hazard ratio of 0.34, a very substantial clinically meaningful benefit from adding hormone therapy. If you are biomarker negative, which importantly is 2/3 of men, all of these men we would normally give hormone therapy, but 2/3 of men would be biomarker negative and do not derive a significant benefit from hormone therapy. We went on, and there's more that is not yet prime time to show you, but we've validated this as a second predictive biomarker to see who doesn't need long-term hormones, 2 years of hormone therapy. On the left here, you can see with a different trained and validated model, we can identify men that do not need 2 years of hormone therapy and the side effects that I mentioned. You got to get it paid. It does no good for me to just present these at national meetings. You got to actually, because these tests, they want to charge $1,000 a pop. Now that CMS covers it, it's usually effectively almost free for patients. Because you get CMS approval, you generate level 1B evidence. It's now the first AI predictive biomarker, or any AI biomarker, in the entire NCCN guidelines. And it has direct treatment implications to how we manage patients and who we give hormone therapy to. So I say this as someone that started off not as the nerd I am today, that if I can do this, I promise you, you can do it too. But remember, it is very easy to create models, whether it's with MRIs, whether it's in cardiology, oncology. They have no value just creating a preclinical model or a retrospective model. They'll never be used clinically. The goal of cancer research at its core is to decrease the suffering of cancer. Some would say to eliminate cancer, but it's definitely to decrease the suffering of cancer, and don't forget this. Thus, the work you do should eventually reach the patient. So you have to keep going, don't give up, in order for this to actually reach the patient and them have access to it. Thank you very much for coming today. I really appreciate it.
Dr. Spratt, I'll go ahead and start off. Dan, I think what really struck me about your talk was there are thousands of biomarkers over decades that have been discovered. Why are so few of them actually incorporated into guidelines?
Yeah, so it's speaking probably more intelligently about prostate cancer is even, I listed here 3 tests, for example, and I'll go right here. These are what we consider these 3 tests. There's tens of thousands that will never reach the guidelines. These 2 bottom ones will probably be dropped from the guidelines because they simply did the retrospective studies, many of them, but never invested and took the risk to say, let's actually test this with real quality randomized trial data. One of them actually did, and it was negative, did not validate. So there's a risk to a company that they have to make that decision. Can I get some uptake in use and sales? Or do I really want to become the oncotype for breast cancer? I think in reality, as many people, they create something very cool. I mean, I've made tons of models that'll never be in guidelines, but you kind of know deep down that it's not good enough, or that it may not pass, muster to put this forward. You have to have a large body of work to convince, for example, CTEP, to say we're going to consume this unbelievably valuable tissue. So to get to that stage, right, we've probably had dozens of institutions where we retrospectively profiled to get as best data as we can. So it's, I think, persistence. I'm not saying people are lazy, but persistence to keep thinking of how do you get this to a patient. And often I feel like people create it because they've got their biostatisticians or AI scientists, and they think it's cool, and they do some really fancy work, but it's not good enough, or it's not clinically relevant to get to patients.
Yeah, that's a great question for you. In your 22 gene genomic classifier, or your subsequent one, have you identified any targets of interest? So can we move beyond androgen deprivation into actually targets of treatment?
It's a great question. So this is one of the big problems in prostate cancer, in the sense, because of that side effect profile, is prostate cancer has had one of the first targeted therapies, right? It is unlike where breast cancer will have ER positivity. Prostate cancer is like 95% AR driven. So its target is the androgen receptor. You shut it down, the tumor, it stops proliferating. It works. So they have tons of different types of ways to inhibit. They now have AR degraders and all these things, but they have the same exact side effect profile. So the short answer is no. What we've learned through one of the really nice, unexpected byproducts of this is we continued and encouraged the company that now bought Decipher, called Veracyte, to keep using a whole transcriptome microarray, not just the 22 genes by like PCR to make it cheap. And with that, we can now really understand the biology of prostate cancer in like 100,000 samples. And we have there's a molecular subtype of prostate cancer now that we're going to be putting forth that, regardless of your PSA, your Gleason score, all this stuff, it doesn't seem to ever metastasize. It's good. And so we're going to be starting a trial that even in men right now, every man would get surgery or radiation. We cannot find a single part of this phenotype called luminal differentiated in any metastatic cohort. They don't metastasize, and if that's the case, then we should spare them, the side effects we cause.
One more question.
Yeah.
Is this on? Yeah.
And they're going to do this AI work actually in head, neck, and breast cancer as we speak.
Oh, that's great. My question is about AI.
Okay.
Great talk, Dan. So, you digitized all these slides. I assume this was a supervised learning module through AI, or so it's self-supervised.
It's completely actually. So one of the to what Ted's point is, so there's different groups who will take a pathology slide and annotate all the human interpretable features. That's fine. I would say people are more comfortable doing that because it's what us as humans recognize. The limitation of that is you're only looking at things we recognize. And so by getting such a huge amount of data, we specifically wanted to skip the steps, so it's completely unsupervised. These slides, literally, there's no annotation at all.
So it's all generative then. It's all
correct. Exactly. So it's looking at. We're now trying to do explainability of what it's looking at, and I can tell you some of it's obvious, some of it no freaking clue what it's looking at. So it's a lot of work going into it. So Atala Beydoun, who's one of the physicians Ted helped me recruit here, he's an AI scientist, got his PhD here at Case Western, is doing explainability work on these models.
Great. I mean, that was the question I was going to ask. What are the features? But since it's generative, I think you're going to need to figure that out.
Yeah.
Great talk. Thanks.
What that brings up for me is, are we going to, sorry, Cliff, but not need pathologists anymore?
So I spoke as Cliff. So I spoke actually at Cliff's annual retreat last year. I think that the short answer is yes, we'll need pathologists. Long answer is I view this as an unbelievably exciting time for pathology, that I guess we need to invest in pathology to get them high throughput scanners and all these things, because the models, and there's companies like there's this ARIA Matrix company. I've sat next to these private practice pathologists, and they have like 10 AI models. It instantly reads where's the cancer, the Gleason score, cribiform, etc. It's not 100% accurate, but imagine that resource for a pathologist would be very helpful, because there's millions of prostate biopsies every year, millions of negative ones, looking at 16 cores. I think this is an efficiency gain that we'll still need pathologists for. I don't know, Cliff, if you agree with that.
I'll just quote another chair of pathology around the country who a few years ago said, digital pathology is not going to replace pathologists, but pathologists who learn how to use digital pathology, and I would extrapolate to other tools that you're talking about here. Well, the pathologists who learn to use those tools will replace those who do not.
Yeah.
Ah, very good. And on that note, I want to thank Dr. Spratt. I'd like to thank everybody for coming. And great job, Dan.